Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast. My name is Terry Fletcher, and welcome to the 118th episode of the CodeCast podcast. And we also did it. We're at a milestone this week of over 100,000 listeners. So I'm really proud of that number, and thank you to everybody who supports the CodeCast podcast. We are actually at almost 2 years and 2 months now. So that's kind of fun, just knowing how long we've been around, that we've got some sustainability. Remember, podcasts usually kind of die about after the seventh episode, and to have 118 episodes now, that is crazy to me. So, and it takes a lot of work, a lot of effort by a lot of people. I have a great production team, and also some people that really help me with some content. So I really appreciate that to everybody. Okay, so let's take a look today at what we're going to talk about. And I really want to talk about and focus on chronic care management, so care management services. I did an episode that just introduced these codes and services back in March of 2018, so a long time ago. But I've had so many practices emailing me and contacting me about how to start implementing these services into their practices. And there's a lot of third-party vendors out there that aren't doing you any justice. So I felt it was time to revisit the topic, especially since Medicare increased our payments for them in 2020, which included the offering on a MIPS MACRA pay-for-performance bonus, because you're offering a value-added service to the patient from a non-face-to-face scenario. And also, you should know OIG, so Office of Inspector General, is looking closely at these codes for compliance and making sure that you are following the rules. So definitely time for a revisit and to discuss specific rules for coding and compliance, and making sure that when you're reporting these services that you're doing it accurately and your documentation can stand up to any scrutiny. But first, the CodeCast podcast is brought to you by the Mayo Clinic, an integrated clinical practice, education, and research institution specializing in treating patients, the #1 hospital in the nation. Nowhere to go: Minnesota, Florida, Arizona. mayoclinic.org. The CodeCast podcast is also brought to you today by the FIA Group, an experienced provider of healthcare cost containment techniques, offering services designed to control healthcare costs and protect plan assets. FIAgroup.com. Okay, so let's take a look at these chronic care management services. And if most of you have received your CPT book for 2020, and I say that loosely, hopefully you have, I use the professional edition, which is the spiral bound, and there's a new sticker on the front that shows the authentication for the American Medical Association. But I'm in the E&M, so Evaluation and Management and Care Management Services section, page 50, and it goes on through page 52, it looks like, because there's also complex chronic care management. But I wanted to go over these services because there seems to be I don't want to say a misconception, because I know I use that word quite often, but there just seems to be some confusion. How about that? And when you can use them, how you can use them, and who these services apply to. And also there's going to be situations where what are you trying to support? What is the service going to do for the patient? Remember, no matter what we bill for, we still have to reflect medical necessity. And so just basically saying we have these services isn't enough. You have to also make sure the patient, first of all, qualifies. Secondly, you've got the documentation and the staff to support providing the service. And you also have to have a buy-in from the patient, because they will have a share of cost. It will be applied to deductible and copays and things like that. And so for services that are not face-to-face, that Medicare and many other payers will allow, there has to be consents where you can bill for something and the patient knows they're going to have an out-of-pocket. And they need to understand exactly what it is you're billing for, and help them to understand that it's a time-based code, meaning that their availability on when you can call them and contact them and have communication with them is going to be important, because you're going to have a threshold of 20 clinical minutes per month that you have to hit to be able to bill a 99490 CPT code. So care management services are management and support services provided by clinical staff under the direction of a physician or other qualified healthcare professional, that may be provided personally by the physician or other qualified healthcare professional to a patient residing in their home or in their domicile, which means, where they live, a rest home or assisted living. So they can't be in a SNF. They're not in the hospital. These are patients that have already left that type of setting. And now they're kind of on their own, if you will. Even if they've got family support, they still need this ongoing management or care because of what they're dealing with from a clinical standpoint. So the physician and or the qualified healthcare professional, and instead of keep saying that, what I'm talking about is nurse practitioners, PAs, and clinical nurse specialists. So someone that can bill directly to the payer, and that's who's going to be providing the service. Now, can you have a team of clinical staff under those professionals? Yes, you can, but they have to direct the care. So the plan of care must be documented and shared with the patient and her caregiver. The care plan is based on a physical, mental, cognitive, social, functional, and environmental assessment. So the initial comprehensive plan, it looks at all healthcare problems. It's not just limited to, let's say, if you're cardiology or your pulmonology or, family practice is everything. But if you're limited to a certain specialty and you take this on, you're basically saying you're going to help direct and coordinate some of the specifics of their care in regard to everything they're dealing with. So what do these services include? So communication and engagement with patient, family members, guardians or caretakers, surrogate decision makers, maybe professionals regarding aspect of the patient's care, communication with home health agencies and other community services utilized by the patient, collection of health outcomes data, if there's any kind of registry documentation, the patient and our family caregiver education to support some of the self-management things they deal with. So independent living, activities of daily living, assessment and support for treatment regimens, and also making sure that they're adhering to their medication management. So one of your team members can be a pharmacist. Identification of available community and health resources for the patient, Meals on Wheels. This is all about how to support them, but it's coming from a clinician, and dietary concerns. It can equal clinical time if that's a patient, let's say, who's diabetic or, who has certain issues that need to be addressed from a dietary perspective, or even if you're coordinating oxygen for a COPD patient. And then also facilitating care for a patient and or family that they may not know they need management on. The other thing is you're going to be dealing with review of laboratory tests and other studies, but those are things that are not reported as part of the E&M service. So remember, this has to be separate services that you're dealing with. Now, here's another aspect of it that I think some people miss. The care management office or practice must have the following capabilities. If you don't have this, don't engage in it. So you have to be able to provide 24/7 access to either a physician or a qualified healthcare professional and clinical staff, including providing the patient's caregivers with a means to make contact with a healthcare professional in the practice to address any urgent needs, regardless of the time or day of week. It says that right in CPT. So if somebody needs to call you at 9 o'clock on a Sunday, there needs to be a clinician available. And what this is for is, and I'm going to tell you kind of the breakdown a little bit on who qualifies in a second, but think about a patient who is, 85 years old, they're on medication, and they're taking their meds, and all of a sudden they forget. And, elderly patients forget a lot of information. And so they're scared, they're afraid, and they're thinking, oh gosh, I didn't take this pill. Should I take it now? Should I wait till tomorrow? And believe it or not, a lot of those patients call 911 and ask them, what should I do? Or they call the hospital thinking that the world's ended. And in effect, they just need to talk to somebody to calm them down, let them know it's okay, and what they need to do. And so that needs to be somebody that's okay wearing a cell phone that is accessible from a number from a patient. You also need to provide continuity of care with a designated member of the care team where the patient can schedule successive routine appointments for this non-face-to-face. provide timely access to follow-up after an emergency visit to the actual office, utilize an electronic health record system so that the providers can access the clinical information when they're speaking to the patient. Also, any kind of standardized methodology to identify patients who require this services. Have an internal care management process, use a form and format. You need to have some kind of a log and then a discussion log. So it's some kind of a spreadsheet saying, when the patient was called, how much time was spent, what the discussion was, and what the patient's response was. And then also be able to engage and educate patients and caregivers, as well as coordinate care among all service professionals for each patient. But here's the thing that is really important. You need to know who qualifies for this service. And this is where some of the third-party vendors that are out there, that obviously I can't talk about as far as an actual name of them on my CodeCast, but if you want to help set it up, feel free to email me and I'll talk to you about it. But when some of the third-party vendors are out there saying every patient that's old can qualify, that's not true. So first of all, chronic care management services are at least 20 minutes of clinical staff time directed by a physician or other qualified healthcare professional per calendar month. Okay, so per that 31 day period. You have to have these 3 elements, and all of them have to be fulfilled to be able to bill for it. So they have to have at least 2 or more chronic conditions expected to last at least 12 months or until the death of the patient. Okay, so they would have maybe COPD is one I mentioned earlier. Maybe they are uncontrolled hypertension. Maybe they're insulin dependent diabetic. Maybe they're a peripheral vascular patient that has ongoing open wound or sores or ulcers. That's a problem. The patient's on oxygen. But here's the second thing. Some of those patients actually could be doing okay, because the second criteria is that the chronic conditions place the patient at significant risk of death, acute exacerbation, decompensation, or functional decline. You can have a patient who is, let's say, hypertension patient. That's a chronic condition because they're probably going to be on medication for a while. But that's not necessarily a patient who's in a functional decline. A lot of patients are well controlled and doing fine. Same with diabetic patients. Yes, they take longer to heal in certain circumstances, but you have to know you're going to have some diabetic patients that are not going to want to buy into this. But as soon as you start having those heart failure patients, those pulmonary patients, those COPD patients, those cancer patients, all of those patients where there's issues where a comprehensive care plan needs to be established, implemented, revised, and monitored. And that's the third criteria. And you're going to stop them from being readmitted because of this care management, then you can bill for these services. It also talks about in CPT that if you have less than 20 minutes, so let's say you just have 19 minutes because you couldn't get a hold of the patient for 2 of their scheduled calls, you can't bill for anything. So it's very important to make sure that you are going to have certain patients that are not going to have a time that is going to equal 20 minutes. And so that population would not be billed. And so I'm not saying it's a waste of time, because you'll still get to have it as part of your MIPS reporting, but it's not going to be part of your chronic care management services. But these services, again, the code 99490, you want to look at page 50 and 51 in your CPT book, read through the guidelines, determine if it's something you want to do, and also make sure that you've got some kind of a mid-level provider that wants to run the program. I just think it's a really important program from a care management perspective, and really a value-added service for patients that can make you some money, there's no question. But the biggest thing about it also is that it speaks to patients in your practice. They now have somebody, it's almost like a kind of a side concierge medicine, where they have somebody they can contact. It's not a 911. You always want to make sure they know this is not a 911 call, but it's just a collaborative effort to try to keep the patient as comfortable and as healthy as possible when they're going through some of these harder conditions that they're dealing with. So for those of you that wanted to implement that, feel free to email me at terryfletchercpc@aol.com. Happy to give you a toolkit Now, that is if you're part of our service. So you want to join our Coding Corner membership first. And we're more than happy that you can do it at terryfletcher.net. More than happy to set you up with a toolkit, let you know how to implement it, and walk you through the steps. And I know that I just set up a couple of practices. One had 3 physicians, and in 6 months, they took in about $80,000. Another practice had 10 physicians, and they took in about $320,000. So it's a money-making service, but it's also a very much a value-added service. But you have to have patient buy-in, and you have to do it right. So if you're interested in some value-added service like that, and you feel that you have that patient population, I know I've got a lot of sicker specialties that listen to the CodeCast, then it might be something you want to take a look at. Okay, so speaking of sick patients, my coding question today is about a certain device, and it's called, you probably heard it called an Impella device or a ventricular assist device, so the acronym VAD, and it's percutaneous insertion typically for arterial access. You can also have venous and arterial access, but what is it exactly? So this is a device, and it's for patients with severe heart failure, cardiogenic shock, or high-risk intervention patients. What it does is it's a device that the catheter is inserted into the patient's femoral artery. A camera is then used to guide the Impella catheter into the left ventricle, and then the Impella works by sending blood from the left ventricle to the ascending aorta, which is the main blood vessel leaving the ventricle. So it's helping that heart pump, okay, and that's what that's for. Otherwise, if you're not on there now, it's different than an aortic balloon pump, but this is now the ventricular pump. So you're trying to make sure that that's helping send that blood through that ascending aorta and back around. Now, a question came in from one of my California subscribers that said, Terry, we're trying to get paid for both the 33990, the Impella implant, and also the removal of the implant, the VAD device, 33992, and we can't seem to get that paid. So I said, okay, well, let's see what your report says. Well, here's the problem. Because this the original code, the 33990, that does include inserting and removal if it's done on the same date. So the 33992 code states removal of percutaneous ventricular assist device at separate and distinct session from the insertion. So they're usually talking about a different day or a complete different session. So if it's during the same session where they remove it, where they were able to fix the problem during the major procedure, typically during percutaneous interventions for the heart, then you're not going to be able to code for that extra. So I've heard that come up a couple of times. Our coding question today was brought to you by HealthTerm, 100% web-based enterprise terminology system that enables data exchange and semantic interoperability in healthcare, a product of CareCom, carecom.com. So my personal tidbit this week is kind of personal and also has to do with business. A couple of shout outs to some podcasts that, if you're interested, that hopefully will be very helpful to you. So I mentioned before the PACOM podcast, that's Professional Association of Healthcare Office Managers, and you can find that on all platforms. It's called the PACOM podcast, Medical Office Management Radio. And then also a colleague of mine, Tony Elholmes, and also one of my business coaching clients, she just started her podcast, and that's the Alpha Coding Podcast, and she's got some great tips, and that comes out every Monday. So make sure you look at the Alpha Coding Podcast. And then also remember, I'm dealing with a lot of different podcasts right now. I'm on Talk 10 Tuesday, which is through MedLearn, and also ICD-10 Monitor. So you can find that on all downloadable platforms as well. And then I know I've been promising for months my business collective, but I promise you that is coming out by the end of this month. There's nothing stopping me now. I've caught up on every possible audit and things I'm doing, and I'm not traveling as much. I actually really cut back almost 50% on my travel starting in 2020. So I'm actually really excited about that. I've been traveling, you guys, for a good part of 25 years, and I'm ready to keep a lot of things local. Now, I'm not saying I'm stopping traveling. Remember, I get invited to conferences to speak, and I'm in Hawaii every September for AAPC. And there are a couple of conferences that have asked me to speak, one in Florida and also one in Chicago. So there are some things that I will be doing, but just as far as seminar circuit, I've actually cut way back. But so I will be doing a lot more webcasts, a lot more podcasting. Right now, I'm up to 6. My Bun Life is coming back. I've always got the Steel City Underground for football. And so check out some podcasts. I'll be able to find a link on my website as well. So that's it for me today on this Terry Tuesday. Everyone, make it a great day and a great week. And thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.